Yeah, very good. This to calculate the depth of ET tube both by oral route as well as by nasal route. It's called Chula formula. Estimate the length of ET tube or a nasal equation based on the distance from the right upper canine to zero point 0.2 centimeter above the carina. Okay? So the calculation, this is for mainly adults only. Uh, 4 plus height in centimeters divided by 10. That will give the ET tube length for oral intubation. For nasal intubation, it is 9 plus height in centimeter divided by 10. Okay? What is Perry's formula? Where is it used?
Central venous line depth insertion.
Central venous line depth. Insertion of left-sided W tube in the bronchial tube. Okay, for that you use the Perry's formula, where it is actually height plus 12.5, or for every 1 centimeter increase in 5 centimeter height of the patient, body height. So for a 170 centimeter patient, it will be 29.5. So we have to add 12.5 like that. Which of these obesity drugs have been shown to result in largest weight loss after 1 year? Liraglutide, semaglutide, pentaramine, topiramate combination, tirzepatide. Yeah, it is tirzepatide, last one, not liraglutide. So, is GLP-1RA associated with lowest risk of gastroparesis?
Semaglutide, sir.
Semaglutide, correct. It is semaglutide is the drug which is resulted in. Now you have been shown in ECG, a 78-year-old man with history of heart failure presents for routine follow-up 1 week after insertion of a pacemaker. As part of evaluation, a 12-lead ECG is obtained. What does the ECG show? Are you seeing any pacemaker spikes with a normal chorus? There is a regular rhythm at the rate of 110 beats per minute. P waves occur before QRS complex. The stable PR interval of 1-2 seconds. The P waves are positive in 1 and 2, AVF, V4 and P6. So this is a sinus tachycardia. The patient's P wave is present in all that. You can see that P wave is here, P wave is here, and the AVF also has P wave, and V4 to V6 all have P waves. Okay. Now, the pacemaker stimulus occurs before every QRS complex. They have marked this here. It is considered as atrial sense and a synchronous ventricular dysfunction. However, there is a beat to beat variation in complex morphology. The odd numbered QRS have a normal morphology and has a duration of 0.8 seconds. Suggests that complexes are not caused by the pacemaker stimulus but rather by native QRS complex. How to prove that? This arrow marks, the star marks which all show the QRS complex, they are from the native one. The even numbered QRS complex QS morphology leads in V1 and P6 in tall T wave lead to or biventricular pacing, indicates that it's the result of biventricular pacing. Therefore, there is an intermittent failure of left ventricular capture happening. Of course, this is a little complicated. So not just go through that. Now, what is capnometry and capnography?
Capnometry is a measure of end-tidal carbon dioxide, and capnography is the graphical representation of it.
Waveform, yes, it's a number. Capnometry is simply the number that is given, and it's a numerical measurement of carbon dioxide concentration or partial pressure in gas sample. Whereas capnography is a continuous monitoring of concentration of partial pressure and the gaseous plotted against time. What is colorimetric capnography? It means the presence of carbon dioxide by pH dependent. What is the technique used in carbon dioxide measurement and why? What is the wavelength of absorption?
Wavelength is 456 micrometer.
What is the technique called? Any technique? Pulse oximetry or
Spectroscopy.
Infrared
infrared absorption
Spectrograph.
spectrography, the most common technique. It is used same for pulse oximetry also. Yeah? It is used because of its simplicity, accuracy, and reliability. It is based on absorption of infrared with a wavelength of 4.27 micrometers by carbon dioxide. What is collision broadening, its effect, and how it is rectified? During capnography, this is one of the questions that can be asked in the exam. Collision with the other molecules such as oxygen or nitrous oxide broadens the absorption spectrum of carbon dioxide, causing a small error in measurement. This is what is called collision broadening. A correction factor is applied in modern analyzers which monitor the other gases in the mixture. So if you go and see your capnography monitor tomorrow, there will be a option N2O compensation. If you press that, then you will get the accurate value. Otherwise, there will be a slight error in the CO2 value that you get. The further refinement is microstream technology, which is highly specific to carbon dioxide and not affected by other gases. The sampling rate in these monitors is much lower, making it suitable for smaller patients, especially pediatric age group. What are the sources of apparatus dead space? Why and whom it is very significant?
length of the circuit, sir. Any Y connectors that are used.
Okay.
It is significant in infants, sir.
Small children who have a cerebroplasty. Okay. Sources of apparatus are heat and moisture exchanger, catheter mount, and other connectors mainly. Okay. This causes hypercapnia, which is reflected in higher end-tidal carbon dioxide. This is significant in infants and neonates. Okay. Adults may not have much problem, but children will have it. What is the difference in carbon dioxide measurement between intubated and non-intubated patient and why? It's a recent article by the WFSA, tutorial of the week, about CO2 measurement in non-intubated patient. So all these questions I have picked up from that. So these recent articles, I think that nowadays the examiners pick up theory questions also from that and ask you questions also from that. Okay, the normal capnography waveform of an intubated patient shows the 4 phases. Okay, phase 0, 1, 2, and 3. Okay. Whereas in a non-intubated patient, it will be more like a inverted V. It will not show the classical 4 phases. Okay. In non-intubated patient, the waveform is more reduced and the peak of CO2 value does not Reach that like artificial CO2 level consistent with exhale mixture with an ambient air and any supplementation. So the display value also varies with the amount of dilution and distance from the nose and the monitor. In what way CO2 measurement in non-intubated patients is useful? Supposing you are giving
Versus adequate
supplementation,
ventilation.
yeah, the waveform in non-intubated patient is confirmation that ventilation is taking place and allows to determine the respiratory rate of the patient. Because that graph will go much faster. Changes in the waveform pattern and rate are helpful in deciding whether any intervention is necessary. Thus, non-intubated capnograph is a quality assessment of ventilatory status using exhaled CO2 as a tracer gas. So, what is shown in this picture?
The capnography is connected using a 10 centimeter to a Hudson face mask.
Hudson's face mask, very good. Hudson's face mask is typically modified by connecting a sampling port to the bowel of the mask. Which device measures carbon dioxide more correctly in non-intubated patients?
Side stream sampling, sir.
Side stream or mainstream. It is not side stream. Mainstream carbon dioxide sensors which have been modified for non-intubated patients by using a small lightweight sensor that can be fitted to the mask or nasal or oral adapter, measure carbon dioxide better than face mask. So mainstream is used mainly for non-intubated patients. Now something with regard to the again research methodology and other things. Define meta-analysis.
Lots of previous studies are
Different,
taken and inferences obtained from.
Define that
derive
a
a single
quantitative
conclusion.
formal epidemiological study design used to systematically assess the results of previous research or derive conclusions about the body of research. So typically, but not necessarily, the study is based on randomized controlled clinical trials. So it is a analysis of a work done already and published. So you take a period of say 4 years, take a particular topic and see who are all published papers, and then try to collect the information from that and then analyze. That is why it's called meta-analysis. What is the aim of meta-analysis? Aim is conduct the strength of evidence present on the disease and treatment. One aim is to determine whether an effect exists at all or not. Another aim is to determine whether the effect is positive or negative, and ideally to obtain a single summary estimate of the effect. What is the need for meta-analysis? This is the third question. I will just not wait for your answers. I will just show you because this topic is not very frequently dealt with. So to establish statistical significance with studies that have conflicting results and to develop a more correct estimate of effect magnitude. And to provide a more complex analysis of harms, safety data and benefits. To examine subgroups with individual numbers that are not statistically significant. These are the needs of meta-analysis. What are the steps involved in meta-analysis? So there are 4 basic steps: identification, selection, abstraction, and analysis. These are the 4 things. You must first identify which are all the published articles or information that is you can analyze. Then choose the article, take the abstraction, and then analyze each one of them. What are the sources available for identification of studies? That you can go by Medline, Embase, CancerLit, AgeLine, ToxicLine, Index Medicus, and Cochrane collaboration control trial registers. From all these things, you can take the source. Identify this something that you want to study. What are the criteria for selection of studies? So these are all the criteria. Once the author of meta-analysis has assembled a large number of studies, it is important to select the right ones. There are a variety of possible inclusions, whether the study include enough information for analysis within the standard deviation and the standard error, in addition to point estimate. What is the study design, whether it is a controlled trial or a randomized controlled trial, and the year of study, technology or typical dosing changes have occurred, dosage used in the study, language of the article, minimum sample size, whether it has been adhered to, patient age, and the study setting, whether it is in emergency department, outpatient, or inpatient. What is the abstraction? After identification, selection, then we go for abstraction. Once an appropriate group of studies has been identified, the authors have to abstract the relevant data from each study. What are the sources of error in data abstraction? The article may be wrong due to typographical or copy editing errors. Tables can be misinterpreted. Errors can occur during your own data entry or abstraction process. Then what steps can be taken to minimize the abstraction errors? Use 2 independent reviewers. Use a third reviewer or a consensus meeting to resolve conflicts. Train reviewer by practicing with several articles to calibrate. Use a standard form of database which constrains entries to expected range. Report the results of the data abstraction, including the percentage concordance or even a kappa static. Compare abstract and text to look for inconsistencies. What describes the degree between study and variability? Homogeneity and heterogeneity describe the degree between study variability. What effect model analysis should be used in homogeneous and heterogeneous studies? In general, homogeneous studies, researchers should have a fixed effects model. If studies are heterogeneous, then you can go for random effect analysis. What are the quality assessments to be done in meta-analysis? Research questions should be clearly defined. Definition of inclusion criteria for studies should be there. Adequacy of such protocol. Assessment of methodological quality of included studies. Calculation of pooled estimate. Plot of the results. Forest plot. Measurement of heterogeneity. Assessment of publication bias. Funnel plot. What are the advantages and disadvantages of meta-analysis? Advantages is there's a greater statistical power, information data analysis. Meta-analysis are used by researchers to review large and sometimes complex research, greater ability to extrapolate to general population affected, considered an evidence-based resource. That is one of the things. Disadvantages, difficult and time-consuming to identify. Not all studies provide adequate data. Requires advanced statistical techniques. Heterogeneity of study population will give conflicting results. What are the applications of meta-analysis? Pharmaceutical companies use meta-analysis to gain approval for new drugs. That is the main purpose. And clinicians and applied researchers in medicine, education, psychology, criminal justice, and host of other fields use meta-analysis to determine which intervention works and which one works best. And meta-analysis is also widely used in basic research to evaluate the evidence in areas of diverse sociology, social psychology, sex differences, finance and economics, etc. So it is useful not only for our medical field, but it is a general statistical topic. And what is the difference between systematic review and meta-analysis? All of you would have come across this wording, systematic review, in many articles. So both are different lies in the systematic review and meta-analysis. Is systematic review is a research process that answers a question by summarizing evidence, whereas meta-analysis is a statistical method that combines the results of multiple studies. So that is the main difference between that. Systematic review is a research process where you get the answer by summarizing the evidence. whereas meta-analysis is a statistical method combining the results of multiple studies. And both systematic and meta-analysis are considered as the highest level of research evidence when you want to publish and give it to that. Now, bias can happen in research methodology. So this is another question that you can expect in the future. If the same examiner set the paper last time happens to set the paper. So types of bias in research are selection bias, performance bias, iteration bias, and detection bias and reporting bias. So all these things are common bias that is can happen in research. Now, what are CRISPR guidelines? Just like the consort and other acronym they are given, I thought this small acronyms also you should be aware of. Anybody can make a guess? This CRISPR guideline. Okay. Preferred reporting items for systematic review meta-analysis. That is the short form of reporting item. Just like consolidated standards, you have preferred reporting items for systematic review and meta-analysis. So that is another acronym called the Hamstar tool, a measurement tool to assess systematic review. So what are the various study designs and guidelines? Study designs can be case report, observational study, analytical study, randomized control trials, non-randomized control trials, systematic review and meta-analysis, diagnostic test accuracy, interventions for quality and safety of care, economic evaluation of health interventions, and qualitative study. These are all some of the study designs which are there, and the guidelines that you can use for them are the abbreviations or acronyms are given here. Just be aware of that. What does MESH stand for? MESH. This is a common terminology you will see whenever you try to Google and find out something. What does that acronym MESH stand for? Medical subject heading. So the ME from medical, S for subject, H for heading. The thesaurus, controlled and hierarchically organized vocabulary produced by National Library of Medicine. It is used for indexing, cataloging, and searching of biomedical and health related information. Now, what does PICOT stand for? Where is it used? This some of you may know if you have prepared for your exam from the research and methodology angle. If you study that, the PICOT is an acronym for helpful approach for summarizing the research questions that explore the effect of a therapy. So the P stands for population, I stands for intervention, C stands for comparison, O stands for outcome, and T stands for time. So these are the initial four things that you have to keep in mind when you want to take a research subject. Which population you are going to use research, what intervention you are going to do, how are you going to compare the effects on the groups, and what will be the outcome, and what is the time duration you want to do that. Then something about cohort study, which is another terminology which you will commonly come across when you read some research papers. What are the other names for this? So cohort is an analytical study is undertaken to obtain additional evidence to refute or support of existing association between suspected cause and disease. Okay. It is also called the longitudinal study, incidence study, and forward-looking study. What are the features of cohort study? Cohort means it's a group of people. The literal meaning for the word cohort is group of people are identified before the appearance of disease under investigation in them. The study groups are observed over a period of time to determine the frequency of diseases among them. And the study proceeds from cause to effects. What are the indications for to do a cohort study? There is good evidence of association between exposure of disease from other studies, then you can undertake a cohort study. When exposure is rare but disease prevalence is more, then also you can take or do a cohort study. When sufficient funds are available, because it is quite an expensive study, you have to have funds, and attenuation of study population is minimal. That means people who are dropping out from the study should be very, very less. The framework of cohort study is this. You first choose a population and divide them into those who are exposed to some infection and those who are not unexposed, and find out among the exposed how many got the disease, how many are disease free. Similarly, in the unexposed population, find out who all got the disease and who are disease free. So this is the framework that you have to do mainly to find out the cohort study. Types are prospective study, retrospective study, ambidirectional study, and nested cohort. The prospective study is a study started with a sample population. Some among them may be exposed and some unexposed, like as I showed in the previous slide. At the beginning of study, both these groups should show no evidence of disease, should not have any disease. Whereas in retrospective study, here the study outcome has occurred and investigated, select study groups from existing records. So in the prospective study, you study a new thing in a population about which there is no study previously. Whereas in the retrospective study has already been done, and you go back to the records and try to find out something like a meta-analysis. Because of this, it is also called historical or non-current cohort study. Whereas ambidirectional cohort study, it involves the elements of both prospective and retrospective studies. The group is identified from past records, followed up prospectively into future for further outcome. So that is how the bidirectional study is done. The steps in cohort study are selection of study population, obtaining data on exposure, selection of comparison group, follow-up and analysis. How this analysis is done in cohort study is, this is how the exposed group with disease, death or no death, or disease or no disease, like that you can select and then do this calculation. So what is the relative risk and relative risk ratio? This is another small thing that can happen or be asked. Relative risk is estimates the magnitude of an association between exposure and disease, indicates the likelihood of developing the disease in the exposed group relative to those who are not exposed. The ratio of risk of disease is exposed to the risk disease in non-exposure. And this is the ratio, how you calculate it, incidence rate among exposed and to the incidence rate among non-exposed. Okay, after that research methodology and all those jargon about research and statistics, now we go to clinical scenarios. A 75-year-old woman presents to her primary care provider with history of episodic lightheadedness. She has never experienced a syncope. Her only history is hypertension, for which she is taking beta blockers and hydrochlorothiazide. A 12-lead ECG is obtained. This prompts an admission to the hospital. Beta blocker therapy is discontinued. This is the ECG. What is the finding in the EKG?
Heart block, sir.
Excellent. Fantastic. Complete or third degree AV block. What is the ventricular rate? I have told you how to calculate in this sort of cases where you don't have a proper PQRS. Okay. It is about 50. You always take the long strip and see how many QRS complexes are there and multiply it with 10. So here you can see 1, 2, 3, 4, 5 QRS seen. Okay.
Yes, sir.
So 10 into 5 is 50. That is how we calculate the ventricular rate. How to manage this case?
Pacing is done.
Pacing,
Huh?
temporary pacing followed
Pacing.
by
You have to put a pacemaker immediately. Urgent. Okay. By pacemaker insertion. Okay. What mode of pacing is to be done? All of you know the terminologies that are used in pacemaker.
yes, sir.
Chamber sensed, chamber detected, chamber response. No? These three are given the letters. So VDD, this mode is appropriate for the patient with complete atrioventricular block and normal sinus node function. Because you have a P wave here, that means the sinus node is okay. So AV synchronized pacing with the ventricular tracts the atrium until it reaches the maximum tracking. VDD pacing is cost effective and also has a shorter implantation time than DDD systems. Of course, we'll skip this. What is shown here? Okay, it's an anti-reflex needleless connectors containing bidirectional pressure-sensitive diaphragm which have the least amount of reflex. So how does it work? It works like this. It is a normally closed position. It protects from blood reflex. Okay? When the fluid infusion goes, it goes through that without any problem. And when you want to aspirate also, you can do the aspiration, but other times you will not get a backflow. So why are they important? Why do you need these anti-reflex needleless connectors? In which particular gadget use it is very important?
In central venous access.
Central venous line. More than that, when you want to give
Arterial
pain
venous.
relief post-operatively, what gadget you can use which can be controlled by the patient himself? How can
Patient control analgesia.
patient controlled analgesia? Anti-reflex valves will prevent backflow of the secondary and often lower cell lines if there is a distal occlusion. And avoid subsequent inadvertent bolus, especially when using patient controlled analgesia technique. Okay. So, can you identify this? This is another component. What I showed here is a small part of this only. This I expanded and showed, but this is a this is called the multi-lumen connector, including an anti-reflex valve for intravenous fluid and anti-siphon valves for intravenous drugs. Okay. So this is a thing that you can do. What is shown in this USG? It's already written there.
Liver
Stages of pneumonia.
It is already shown here in yellow, lung hepatization. Okay. So what does hepatization mean? Already you have given
fibrosis.
part of the answer. Pneumonia is the answer is correct, but what is the expansion or what is the description for hepatization? Lung
So the
hepatization is a
pneumocytes are
condition
replaced.
where lung tissue becomes more solid and visible on an ultrasound, resembling the appearance of the liver. And it happens because of inflammatory material
inflammation.
like fluid or pulse fills the alveoli of the lung. Okay. Now you are seeing some grading. It's 0, 1, 2, 3. It is written IVC less than 20 millimeter. So what grading is shown here? So time up. It is different grades of venous excess ultrasound score. VAUS. Okay. How is the grading done? What way it is useful?
Sir, when the IVC collapsibility index is inconclusive,
What
So-
happens? What do you see? It is given here normal pattern, mild findings, severe findings only in one organ, severe findings in multiple organ. So that is all given here as a clue.
sir, we take the
What-
renal vein, we take the Doppler of various veins, sir, and
Like various veins with which organ veins you take?
kidney, sir.
Kidney and liver.
Liver.
Okay. So V-axis grading is a system based on evaluation of IVC diameter and venous Doppler waveform of portal, hepatic, and renal veins. Okay. And in the presence of IVC of more than 2 centimeters or 20 millimeters, these veins are evaluated, assigned to as the representative either being normal, high congestion, or severe congestion. So it is one of the method of identifying the right-sided heart failure, because the IVC will be flooded or expanded with a inadequate venous return to the heart, and that will reflect back onto the portal, hepatic, and the renal system. So this is one of the method of identification. That's why it's called venous excess ultrasound score. Okay. Now, an air oxygen blender with E-size cylinders is supplying gas to Mapleson D circuit being used to ventilate a neonate during transport. Okay, an air oxygen blender with a E-size cylinder supplying gas to Mapleson D circuit. What is Mapleson D circuit?
Jack.
JR circuit.
Huh?
Mapleson D.
What is the common name for Mapleson D?
Vein circuit.
Jackson.
Vein circuit.
Vein
Vein
sir.
circuit.
Okay, the air tank is full with the PSI 1900 pounds per square inch, 625 liters, and the flow is 4 liters per minute. Oxygen tank flow is 5 liters per minute, and the pressure gauge indicates 500 psi. The flow rate remains unchanged. Which of the following statement is correct? Multiple choice questions. The air tank will empty in 90 minutes. The oxygen tank will empty in 30 minutes. The concentration of oxygen in the circuit is 60%. The oxygen tank will fill with air with pressure gauge falls below 50. The volume of oxygen remaining can be determined only by weighing the tank.
Sir.
Which answer is correct? You want to make a wild guess at least.
B, sir.
Huh?
B.
B for Bombay.
Yes,
You're
sir.
absolutely right. It is a B. Okay? Because see,
P1 V1 is equal to P2.
PSI is 500. Normal pressure of a full cylinder is
1000.
2000
2000.
PSI.
2000.
Okay, it is 1/4 full. That
Yes.
means 625 divided by 1/4, almost 125. So 5 liters per minute, roughly it will last only for
30
300
minutes.
30 minutes. Okay, your answer is right. Which of the following is most important function of temperature compensation in anesthetic vaporizers? Okay. Compensation for changes in specific heat of anesthetic drug during vaporization. delivery of diluent gas at a constant temperature regardless of flow rate, increase of bypass flow when vaporizer is cooled by high fresh gas flow, maintenance of constant anesthetic vapor output over a range of vaporizer temperature, maintenance of constant vapor concentrations at low flow rates.
Compensation for changes, sir. A.
This is the specific heat of anesthetic during vaporization. Is that the answer?
E, sir, constant vapor output.
That is the correct answer. Constant vapor output over a range of wide temperature. Okay? So it will deliver. That is the way they are called more accurate vaporizers. It should deliver the set concentration. Dial setting should not vary. They based on the temperature. What is compression volume in a breathing circuit and what is its value?
Volume.
Okay, compression volume is the amount of gas that is compressed in an anesthesia circuit when it is pressurized, resulting in increase in circuit volume. The volume can be as much as 3 to 5 ml for every increase in centimeters of water pressure. What factors affect compression volume? Are you all aware of this
Flow.
particular terminology?
No, sir.
No, sir.
So the circuit type, the type of circuit used affects the compression volume. For example, adult rubber circuits have larger compression volume than other circuits. The pressure that you use at which the circuit is examined can affect compression volume. Humidifier, presence of humidifier can affect compression volume. For example, Maples and Beer systems with a humidifier have smaller compression volume than surface system. And what is compression volume? A combination of and which gas law is applicable. That is another thing. Compression volume is a combination of circuit's dischargeability, that is compliance of the circuit, and gas compression. It is based on Boyle's law. When does compression volume become significant? It becomes significant when ventilated with low tidal volumes and high pressure. To detect the delivery of a hypoxic gas mixture, the optimal location of an oxygen analyzer in this circle is, this is the picture. There are 5 locations shown in this. So, which one will be ideal?
4, sir.
4, sir.
4. 4
No,
is
5. Between inspiratory valve and the
inspiratory limb and the patient. Okay. 4 is on the expiratory valve. It's going to the expiratory limb. Okay. So the ideal is E. That is 5. Okay. After removing the electrocautery pad from the thigh, the burn is noted at the site. Which of the following most likely contributed to this injury? A line isolation monitor fault, current leak from EKG module, defective grounding of the electrocautery unit, dried gel on the electrocautery pad, excessive current setting on cutting mode.
defective grounding, sir.
Defective grounding.
Gel,
Defective
sir.
grounding. Huh?
Dried gel, contact.
Dried gel, exactly, correct. So when you use the sticking pad, nowadays many hospitals reuse the pad which is meant for use and throw. So repeatedly, if you're using the same sticking pad, causes the drying of the gel, and that can be the cause for this. In this diagram of a circle system, an increase in dead space is most likely to result from placement of the pressure relief valve at which location? These are all the options. Which will increase the apparatus dead space to keep that valve, pressure APL valve or a pressure relief valve. The answer is
3.
D, 4.
Okay.
Okay. So that will make it a full dead space up to this. So wherever the relief was present, up to that you have to calculate the apparatus dead space. But during general anesthesia administered through circle system, the soda lime absorbent is exhausted. No fresh soda lime is available for use. Which of the following is the most appropriate next step to prevent hypercapnia in this patient? The options are decreasing the dead space of the circle system, discontinuing nitrous oxide, increasing the fresh gas flow, increasing tidal volume, switching to spontaneous ventilation.
Increasing fresh gas flow, sir.
Increasing fresh gas flow. Good. Right. Proper zeroing of an arterial pressure transducer attached to a supine anesthetized patient is best accomplished by continuous flow of fluid through intravascular catheter, opening the system to air at heart level, placement of the transducer diaphragm at heart level, proper damping of the transducer system, and zeroing the transducer during expiration of mechanical ventilation.
Opening the
Opening
system
the
to
system to
Opening the system to air at heart level. Correct. Good. Which of the following is most effective in preventing intraoperative hypothermia in adults? Heating and humidifying inspired gases, maintaining a warm operating room, using a circulating warm water mattress, using reflective coverings, warming intravenous fluids.
C, sir.
Heating
Most
and
effective.
Warm
Huh?
water.
heating and humidifying inspired gases.
Heating and humidifying. All are
Warming.
almost very good effects, procedures to maintain prevent
Warming
hypothermia. But
intravenous
the
fluid.
question is which is the most effective?
operating room, sir.
Intravenous fluids.
Maintaining a warm operating. That is the main thing. If you cool the ambient temperature, then body has to find it difficult to maintain that temperature. So if you have an ambient room temperature at a higher level, all these things will not be required. Okay? So during the use of ventilator on anesthesia machine, positive pressure is noted on the airway pressure gauge during expiration or exhalation. Positive end expiratory pressure has not been purposefully added to the breathing circuit. So which of the following is the most likely cause for a higher airway pressure during exhalation? Closure of pop-off valve in the circle system, excessive tidal volume setting on the ventilator, obstruction of the pressure relief valve on the scavenging system, overinflation of the endotracheal tube balloon, tension pneumothorax. Normally during expiration, the pressure should drop, isn't it? The pressure gauge will go to the zero level. But here it is showing a positive pressure.
Overinflation of the endotracheal balloon.
Overinflation of the endotracheal tube. No.
Tension pneumothorax, sir.
Mhm.
No. The answer is C. Obstruction of the pressure relief valve on the scavenging system. Okay. It usually has a negative suction effect. That supposing there is an obstruction, that pressure will get transmitted during exhalation. So that will reflect on the pressure gauge. Maximum current delivered to the myocardium by a counter shock for defibrillation is when paddle contact pressure is minimal, petroleum jelly is used under the paddles, previous counter shocks of the same power has been attempted, patient is grounded securely, the shock is applied at the end of inspiration. When will the heart receive the maximum current among these 5 situations? The answer is C.
D.
C. And when already we have tried several times shocking the patient and you are doing it again and again, that will produce a much more maximum current delivery. Okay. So a heart which has been receiving counter shocks again and again, that will get the maximum current. During laser microsurgery, the larynx of the larynx using an endotracheal tube, a fire occurs in the airway. Which of the following is the most appropriate initial management? Increase FiO2 to 1, instill saline into the endotracheal tube, perform cricothyroidotomy, remove the endotracheal tube, ventilate with air.
Remove ignition source.
Very good. Remove endotracheal tube. The correct answer. Which of the following is most effective in decontaminating the anesthesia machine that was splattered with HIV contaminated blood? Bleach, deionized water, ethylene oxide, hydrogen peroxide, isopropyl alcohol.
Isopropyl.
No. Next guess.
ETO, sir.
Isopropyl
It is A,
alcohol.
bleach. Okay, bleach is the most important. Which of the following is the greatest disadvantage of pressure cycled ventilation? Increased IE ratio, increased mechanical dead space, increased risk of barotrauma, variable respiratory rate, variable tidal volumes. Barotrauma. Disadvantage. Even during, without barotrauma, what is the thing that can happen when you use a pressure cycle? Is the tidal volume delivery guaranteed?
Variable tidal volume.
So variable tidal volume. That is the answer. Okay. Esflurane is delivered using a vaporizer that contains inhaled internal heaters because heat decreases the drug's viscosity, heat reduces thermal loss in the patient, heat increases the drug's oil gas partition coefficient, heat prevents fluctuation of vapor pressure, it does not vaporize adequately at room temperature.
It prevents fluctuations of vapor pressure, sir.
Very good. D. A 55-year-old man is undergoing craniotomy in the sitting position. Mean arterial pressure is 75 and the blood gas values show PaCO2 41, pH 7.73, but end tidal CO2 is 7 millimeter. Which of the following is most likely cause for the increase in PaCO2 and the PaCO2 gradient? PaCO2 41, EtCO2 7. The causes are decreased cardiac output, endobronchial intubation, hyperinflation of the lungs, partial disconnection of capnographic sampling tube, venous air embolism.
Partial disconnection.
Partial disconnection of capnographic, correct. During extracorporeal shockwave lithotripsy, the shockwave should be synchronized with P wave of the ECG, R wave of the ECG, T wave of the ECG, peak inspiration, end expiration.
Peak inspirations.
R wave of the ECG.
R wave, yeah, that's the contraction, no? It's R wave. So it should coincide with the frequency. On routine inspection of an anesthesia machine, the nitrous oxide E cylinder pressure is 360 psi. This indicates that pressure in the cylinder is 16 atmosphere. Cylinder contains no liquid nitrous oxide. Cylinder is half full. Cylinder contains enough nitrous oxide for 1 hour of anesthesia at a flow rate of 3 liters. And reducing valve is malfunction.
Half full cylinder, sir.
Cylinder is half full. Does the pressure coincide like with
No, sir.
Boyle's law as for oxygen?
No, sir.
Sir.
Ah.
No, sir. Avogadro
What is the
hypothesis.
normal pressure if in a full cylinder of nitrous oxide?
750.
750 psi. Okay, when it starts dropping, what does it mean?
Cylinder is getting discharged.
There is no liquid nitrous
Liquid
oxide
nitrous.
left. Everything has become a vapor now. Okay, so the B is the correct answer. Tracing shown is from a femoral artery catheter. Which of the following is most likely explanation? So this is the tracing that you see. An air bubble greater than 1 ml in the tubing. The diastolic pressure is factitiously high. Mean blood pressure is inaccurate. The normal monitoring system is underdamped. The systolic pressure in the aortic arch exceeds 200 millimeters of mercury.
Air bubble, sir.
Huh?
Air bubble.
Bubble.
Underdamped system, sir.
Underdamping. Underdamping. This is so much of fluctuation, it is underdamping. Okay. The waste gas scavenger has an active disposal system. Which of the following safety features is necessary to prevent removal of excess gas from the breathing circuit? Okay. Positive pressure relief mechanism, negative pressure relief mechanism, low volume scavenging reservoir, high volume scavenging reservoir, maximum vacuum flow of 5 liters per minute.
Maximum vacuum flow rate of 5 liters.
Maximum vacuum flow rate of 5 liters is necessary, isn't it? It's an active disposable system. That means it is actively sucking the exhaled gases. It is not allowing it to passively come. So, how will you suck out?
Negative pressure relief mechanism.
Negative pressure. So,
Negative
unless we have a proper negative pressure relief mechanism, it will cause excessive removal. Okay? That is the word important, active scavenging. Which of the following statement concerning absorption of carbon dioxide by soda lime in anesthetic circuit is correct? A warm canister indicates reserve absorption capability. Fresh soda lime includes calcium carbonate. The granular volume of the canister should exceed the patient's tidal volume. The color indicator is methylene blue. The reaction removes water.
Soda lime includes calcium carbonates.
Calcium carbonate. It's calcium carbonate or calcium hydroxide?
Calcium hydroxide.
Hydroxide.
It becomes calcium carbonate after reacting with carbon dioxide. It
Yes, sir.
doesn't,
Methylene blue.
contain carbonate. Methylene blue is not the indicator.
Phenolphthalein.
Phenolphthalein is the
Phenolphthalein.
indicator.
Color indicator.
Is water removed or water generated by the reaction?
Water generated, sir.
Generated, sir.
So which should be the correct answer? Answer is C. Intergranular space should be equal to or more than the patient's tidal volume. Okay? Otherwise, what will happen? Channeling will happen. If the intergranular space is not large enough to match the tidal volume, gas will tend to go through a main path where it is least obstructed. That is called channeling effect. Okay? Leakage current and microshock hazards are eliminated by an isolation transformer, conducting flooring, with a 3-wire grounding system, a line isolation monitor, none of the above. Answer is none of the above. None of them prevent that. Okay. Most likely cause of this capnograph tracing obtained just after laryngoscopy and intubation is esophageal intubation, partial obstruction of the endotracheal tube, pulmonary embolus, insertion of endotracheal nasogastric tube, mild bronchospasm.
Esophageal.
Esophageal intubation.
Esophageal, easy. Esophageal intubation. The Borg RP scale, where is it used? This is what I told you in the rehabilitation slide and told you I will show you that. The Borg RB scale. The rating of perceived exertion scale. Borg rating of perceived exertion scale. It is subjective tool used during exercise testing and training to estimate the effort based on how the patient feels. The various ratings in the scale are starting from 6 to 20. No exertion, maximal exertion at 20, in between light, somewhat hard, very hard like that. What does the scale correlate with? Correlates with heart rate, ventilatory frequency, serum lactate, percentage of maximal oxygen consumption. Okay. Then it was modified. This is the original Borg RP scale. It was modified later. So from what was 6 to 20, it was modified to rating from 0 to 10. It uses a scale of 0 to 10, where 0 means no difficulty or no breathlessness, 10 means maximum difficulty, unlike the original scale which ranges from 6 to 20. What is ABO incompatible kidney transplant? Idea? So an ABO incompatible kidney transplant is a kidney transplant between recipient and donor with incompatible or different blood groups or blood types. Okay. Normally, we choose only the same blood group donor and recipient, because just like wrong blood group transfusion can cause mismatched transfusion reactions. Same way, organs also can be rejected if you have no ABO compatibility. But nowadays, we are doing this. You could have seen in the paper some time back that a rare blood group called Bombay O blood group, patients with mismatched groups were transplanted in Miyat Hospital only.
Yes, sir.
Published an article on that. So what is the benefit of ABO incompatible transplantation?
Graft rejection.
It makes more efficient use of whatever available organs are there, especially when a recipient cannot get a compatible donor. You can use this technique. So what has made ABO incompatible transplantation possible? What are the advancements in the preparation of the patient, which helps to do even an incompatible blood group transplantation possible? It is because of desensitization. The main worry is if you do the incompatible group, the antigen antibody reaction will happen and the organ will be rejected. That is the most dreaded danger of this incompatible group transplantation. So what they have done is they have removed all the antibodies from the recipient, which will be supposed to react with the antigen of the donor. So when there are no antibodies to react with the antigen of the donor kidney, then the organ will not be repelled. So that is how this technique came into practice. So what are the methods of doing desensitization? Any idea? Your students should be able to answer this, because your hospital is doing this routinely. Are you all posted in transplant theaters?
Yes, sir.
Transplant? Yes. So have you not seen a incompatible transfusion, transplant being done? So there are three techniques which are followed. One is plasmapheresis, and another is adsorption. Third is B cell depleting therapies. So there is a procedure called glycosorb procedure. This procedure is a continuously treat the recipient blood with plasma glycosorb ABO filter, until the antibodies in the patient that react to foreign blood groups are selectively removed from the recipient's blood As a result, the body does not repel the transplant organ in the later stage. So this is the glycosorb ABO system. The blood is taken out, then it is centrifuged and separated. Blood cells are returned back to the patient. We take the plasma which contains the antibodies and we use this absorption system and remove the antibodies, and then we inject the plasma back into the patient. So just something like a dialysis. So you can do it during dialysis also. Use the same filter to remove the antibodies from the recipient and do the dialysis also. And then you fit the other group donor organ into the patient, it will not get rejected. So the comparison between absorption and plasmapheresis are immunoabsorption is more efficient compared to plasmapheresis, which is less efficient. And you selectively remove only the IgA antibodies, whereas here you select all the proteins, remove all the proteins in plasmapheresis. So patient may lose all the other coagulant proteins also in plasmapheresis. So you have to replace them after doing plasmapheresis. And immunoabsorption is less complicated, just like doing a dialysis, you can see in this picture. Whereas plasmapheresis is more complicated, and you can treat higher plasma volumes with the immunoabsorption, whereas you can treat only or remove antibodies from a lesser plasma volume. So these are the things that you have to remember with the Osce for today. Okay.